Extrauterine Pregnancy Audio Course, Episode 7, Stable Tubal Ectopic, Selection, Not Reflex. Once tubal ectopic pregnancy has been diagnosed, the first clinical question is not, which treatment do I usually use? It is whether the patient is well enough for a planned treatment pathway. Hemodynamic instability, peritoneal signs, substantial hemoperitoneum, or a clinical picture of rupture moves the patient into urgent surgical care. Stability changes the tempo. It does not by itself choose the treatment. In a stable patient, the decision rests on 4 domains: the clinical condition, the ultrasound appearance, the HCG pattern, and the reliability of follow-up. These domains belong together. A patient with little pain, no concerning free fluid, low and falling HCG, and immediate access to emergency care is biologically and logistically different from a patient with the same blood pressure but severe pain, fetal cardiac activity in the ectopic pregnancy, rising HCG, or no realistic way to return for serial testing. Expectant management is easiest to misunderstand because its name sounds passive. In ectopic pregnancy, it is a treatment strategy built around the natural history of a failing trophoblast. Nature Review's disease primers describes that many tubal ectopic pregnancies develop abnormally and have limited capacity to grow. As the pregnancy regresses, trophoblast function declines and HCG clears from the maternal circulation. The retained tissue may take longer to disappear on ultrasound, but the active biologic signal is falling.
That biology explains the patient selection. Expectant management is considered only for a carefully selected, stable patient who is asymptomatic or minimally symptomatic, has low and declining or low-risk HCG values, has no ultrasound evidence of rupture or dangerous bleeding, has no fetal cardiac activity in the ectopic pregnancy, and can comply with follow-up. NICE uses lower HCG thresholds, commonly below 1,000 to 1,500 international units per liter, while ACOG allows that selected patients with HCG below 2,000 may still be suitable. NICE also uses an ectopic size below 35 millimeters in its expectant pathway. These numbers are not a declaration that rupture cannot happen above or below them. They mark the zone where spontaneous resolution is sufficiently likely that surveillance can be a defensible first treatment. The thresholds should be remembered by the biological state they describe. Expectant management belongs to quiet disease. Low HCG, falling or low-risk trajectory, small ectopic size, no heartbeat, no concerning blood, minimal symptoms, and reliable follow-up. NICE's 1,000 to 1,500 range is a stricter quiet disease zone. ACOG's selected use below 2,000 is a somewhat broader zone. The 35 millimeter size threshold in NICE is another way of asking whether the visible ectopic burden is small enough to watch. None of these numbers mean safe forever. They mean safe enough to justify time if the patient remains clinically well. The newer treatment evidence reinforces that point. The Van Mello randomized trial compared systemic methotrexate with expectant management in stable women with ectopic pregnancy or pregnancy of unknown location and low HCG concentrations. Salangan's 2023 individual participant data meta-analysis focused on tubal ectopic pregnancy with HCG below 2,000 and found no statistically significant difference in treatment success between methotrexate and expectant management. Treatment success was about 79% after methotrexate and about 69% after expectant management, with confidence intervals that did not prove a clear advantage for methotrexate. Methotrexate-specific side effects were reported more often with methotrexate. The practical meaning is narrow, but important. In selected low HCG, stable disease, immediate drug treatment is not automatically superior to close observation. The surveillance is the treatment infrastructure. HCG is followed in the first week, often with day 2, day 4, and day 7 measurements in guideline pathways, and then weekly if the values are falling appropriately. The patient must be told that rupture can occur at any HCG value.
Severe abdominal pain, collapse, shoulder tip pain, new bowel or urinary symptoms, increasing dizziness, or heavy bleeding are not wait for the next blood test symptoms. They are return to hospital symptoms.
Methotrexate enters a different biologic situation. It is a folic acid antagonist that inhibits dihydrofolate reductase, disrupts purine nucleotide synthesis, and interferes with DNA synthesis in rapidly dividing cells. In ectopic pregnancy, the intended target is proliferating trophoblast. That mechanism also explains why methotrexate cannot substitute for surgery in rupture, why it cannot make unreliable follow-up safe, and why its contraindications matter. A good methotrexate candidate is hemodynamically stable, has a confirmed or strongly suspected ectopic pregnancy, has no evidence of rupture, has no current normally cited pregnancy, has no major contraindication to methotrexate, and can complete surveillance until resolution. Baseline evaluation includes HCG, full blood count, liver enzymes, and renal function because the drug can affect marrow and mucosa and must be cleared safely. ACOG lists absolute contraindications that include bone marrow dysfunction, clinically significant renal or liver disease, immunodeficiency, active pulmonary disease, active peptic ulcer disease, known methotrexate sensitivity, breastfeeding, ruptured ectopic pregnancy, hemodynamic instability, and inability to participate in follow-up. The relative contraindications are treatment failure signals rather than moral prohibitions. High initial HCG, embryonic cardiac activity, and a larger ectopic mass all suggest a more established trophoblast. ACOG and Nature reviews describe HCG above 5,000 international units per liter as a relative contraindication, because systematic reviews show treatment failure around 14% when pre-treatment HCG is above 5,000, compared with about 4% when it is below 5,000. NICE offers methotrexate for selected women with no significant pain, an unruptured ectopic below 35 millimeters, no visible heartbeat, and HCG up to 5,000. The shared logic is that methotrexate works best when the trophoblastic burden is limited and the patient is clinically quiet. Now, compare the two 5,000 related uses. For methotrexate, HCG up to 5,000 can still fall within selected guideline eligibility, but above 5,000, failure risk rises enough that ACOG treats it as a relative contraindication. The number is not a cliff. It is a warning that trophoblast burden may be high enough that a single medical dose is less reliable. The resident should hear 5,000 as a prompt to slow down, check mass size and cardiac activity, discuss alternatives, and make sure follow-up is robust. The common single-dose regimen in the United States, the United Kingdom, and Australia is methotrexate 50 milligrams per square meter intramuscularly on day 1. HCG is measured on day 1, day 4, and day 7. The important early response is not day 1 to day 4. HCG may rise during that interval and still be followed by treatment success. The key early treatment checkpoint is the fall from day 4 to day 7. A decline greater than 15% between day 4 and day 7 allows weekly tracking. If the decline is insufficient, a second dose or surgery is considered according to the protocol and the clinical picture. Say the regimen as a rhythm. Day 1 is treatment and baseline. Day 4 is not the verdict. Day 7 is the first formal response check. The fall that matters is more than 15% from day 4 to day 7. If that fall occurs, weekly HCG tracking follows. If it does not, the plan has to change. This rhythm protects the patient from two mistakes: panicking at a day 4 rise that can be expected, and ignoring a day 7 plateau that predicts failure. This monitoring rule is more than a schedule. It reflects the time course of trophoblast response. Methotrexate does not instantly erase hormone already produced by living trophoblast. By day 7, the trajectory should begin showing that cell proliferation has been suppressed enough for HCG to fall. A stable patient with a day 4 rise can still be responding. A patient with worsening pain is judged by physiology, not by a reassuring spreadsheet.
Single-dose methotrexate is not the only medical pattern.
Two-dose and multi-dose regimens exist because not every ectopic pregnancy has the same trophoblastic burden. A small, quiet, low HCG ectopic may need only one exposure to antifolate pressure. A pregnancy with higher HCG, larger mass, or embryonic cardiac activity contains more active trophoblast and is more likely to outlast a light regimen. The regimen question is therefore biological. How much proliferating tissue is present, how likely is one dose to suppress it, and how much toxicity and monitoring complexity is acceptable. The multi-dose regimen makes that principle visible. It gives methotrexate repeatedly, commonly 1 milligram per kilogram on alternating days, with leucovorin rescue on the intervening days to reduce host toxicity, until the HCG response shows sufficient suppression or the maximum planned doses are reached. The two-dose regimen sits between single-dose simplicity and multi-dose intensity by giving planned additional methotrexate exposure early. These regimens are not more sophisticated because they sound aggressive. They are chosen when the disease biology makes single-dose failure more plausible and the patient can be monitored closely. That is the way to remember the names. Single-dose favors convenience and lower treatment burden when the ectopic is clinically quiet. Two-dose increases early drug exposure for patients at higher risk of single-dose failure. Multi-dose is the most intensive classic medical strategy and requires the most attention to adverse effects and response. None of them is appropriate for rupture, shock, inability to follow HCG, or a patient whose symptoms are declaring that biology has already become surgical. Counseling must be concrete. The patient should know that medical treatment usually avoids anesthesia and an operation, but requires longer surveillance, repeat blood tests, and continued rupture vigilance until resolution. She should avoid pregnancy until resolution has been confirmed and follow local post-methotrexate conception guidance, commonly waiting 3 months because methotrexate is an antifolate and early embryonic exposure is unacceptable. She should know which symptoms override the plan. Surgery remains appropriate even when the patient is initially stable if the clinical picture makes outpatient treatment unsafe or unlikely to succeed. Severe or increasing pain, concerning free fluid, suspected rupture, fetal cardiac activity in the ectopic pregnancy, high HCG with a large mass, contraindication to methotrexate, inability to return, or patient preference may all move the decision toward operative care. Diagnostic surgery or uterine aspiration may also be part of management when location remains uncertain and the clinical stakes of wrong treatment are high. The clean bedside sequence is therefore deliberate. First, decide whether the patient needs urgent surgery. Second, if she is stable, decide whether the pregnancy is already failing in a way that makes expectant management reasonable. Third, if active treatment is needed and surgery is not required, decide whether the ectopic biology and the patient's medical condition fit methotrexate. Fourth, make sure the follow-up system is real. Without that system, expectant management and methotrexate both become unsafe. The resident should leave this decision with a specific habit. Do not let the word stable end the discussion. Use stability to open the correct selection process.